All right. Welcome everybody after the holidays, the new year. Seems like the holidays and New Year was a long time ago, but we are back in full swing and glad to have everybody here today. So please, like Rachel said, any cases that you have to present or we can present that for you, please let us know. We're going to start today talking about multiple gestations, and really we're going to talk about twins. I'm not going to talk about higher order multiple simply because they're much less common, and honestly, maternal fetal medicine docs handle those cases for the most part. So we're just going to talk about twins. And the terms can be confusing. They've always confused so many people, including myself. The two types of twins that we'll talk about are dizygotic. Most people, lay people, know them as fraternal or non-identical twins. And it literally is fertilization of two separate eggs. So it's two genetically distinct individuals. This is the type of twins that varies depending on different risk factors. For instance, in Nigeria, the incidence of dizygotic twins can be as high as 60 to 80 per thousand births. In the United States, the incidence is about 12 to 15 per thousand births. So race has a big impact. African Americans have a much higher rate than Caucasians, and Asians have the lowest rate. Increasing maternal age is associated with a higher instance of these twins. The more babies you have, the more likely you are to have twins. I can't tell you the number of times I've had moms come in saying wanted to have one more child, and they come in pregnant with twins. It happens. And then obviously assisted reproductive techniques. Frequently they'll put in two embryos, and two embryos might take. Some docs just put in one, but putting in two increases the likelihood of success. Remember that dizygotic twins, that is non-identical twins with two separate eggs, all have dichorionic placentas, and that's where the confusion comes sometimes. So we'll talk more about that as we go. Next slide. So monozygotic twins are formed from the splitting of a single fertilized egg. So after fertilization, then the egg splits and makes twins. This is pretty constant in rate, about 4 per thousand births across all populations. Almost always these two babies are going to be genetically identical. There's some exceptions to that. We won't get into that. There certainly can be birth defects or anomalies in one that aren't in the other. But again, from a genetic standpoint and chromosome standpoint, they're typically identical, and they share a placenta. So this type of twins can have either dichorionic or monochorionic placentas. Next slide. So these next few slides kind of just reiterate that. I think everybody understands the significance. At least 2/3 to 3/4 are dizygotic. They all have di-di placentation. 1/3 approximately in the United States are monozygotic, and 1/3 of those will have di-di placentation, and up to 2/3 will have mo-di placentation. So again, we'll talk more about that as we cover it today and next session. Next slide. So the monozygotic placenta is determined by the day that the egg is split after fertilization occurs. So the earlier the split, if the 2 to 3 days the egg splits, it's dichorionic, diamnionic placentation. If it occurs between days 3 and 8, monochorionic, diamnionic placenta. Day 8 to 13, which is much less common, less than 1% of pregnancies will be mo twins. That is one single sac with two babies in there. We're not going to talk a lot about that because it's such an uncommon event, but we'll touch on it next session. And then the rarest of all is when that egg splits after day 13. And that leads to the unfortunate incidence of conjoined twins. Next slide. So this is just a depiction of the modi and di placentation. The modi, upper right, you can see a very thin membrane with one single chorion on the outer surface. And then the di, which is two totally separate sacs with two layers to that membrane for each baby. Next slide. Just a brief mention about nutrition. In general, it's felt that twins will require an additional 600 kilocalories per day. And the World Health Organization recommends a weight gain of 35 to 45 pounds in normal weight patients. Now, if a patient is overweight, that can be a little bit more limited. We base it basically on the patient's weights. We have a protocol that we use for that. And they do need an additional iron tablet a day and additional folic acid supplementation because of the increased demands with twin pregnancy. Next slide. So ultrasound is to a maternal fetal medicine like stethoscope to a cardiologist, and ultrasound in management of twin gestation and multiple gestations is critical. A detailed anatomy scan is imperative. And we also do echocardiograms, particularly on our modi twins because of the increased incidence of birth defects. And then we follow these twins with ultrasound examinations throughout the pregnancy, looking for fetal growth restriction and significant discordance. But probably the most important point to make in the whole talk is the documentation of chorionicity, which should be done early in pregnancy in that first trimester between 8 and 12 weeks. Next slide. So this is a picture of ultrasound of that twin peaking. This is at about a 11 to 12 week ultrasound, and you can see that nice thick membrane. This is a di placentation. So when you have dichorionic, diamnionic, two membranes for each fetus, that membrane intervening is very thick, and you see that twin peak. Next slide. So you can click through these, Rachel, because I think it's going to bring up the name at the bottom. But you can see on the left that very thin membrane. This is an 8 to 9 week pregnancy. A wisp of a membrane, that is a monochorionic membrane. So if you look at the next one, you can see that twin peak. So the earlier you do these, this being an 8 week, you can see that twin peak is not quite as dramatic as it was on that 12 week ultrasound. It's still thick in comparison to the monochorionic placentation. Next slide. So complications with multiple gestations are significantly increased compared to singletons, and it makes sense. If you have two fetuses, the rate of all of these complications is significantly increased compared to singletons. Preterm labor is probably the most common, that and anemia, but the other risks are also there. The twin-twin transfusion is seen with monochorionic placentation. That's where vascular sharing is between the two pregnancies, and it can lead to complications. And we're going to talk a little bit about that next session. Postpartum hemorrhage is much more common in these patients, so it's very important to treat anemia if it occurs in these patients so that you can be prepared for that postpartum hemorrhage from the over-distension of that uterus from the twins. And remember, too, that the identical twins have a higher rate of complications in general than the non-identical twins, primarily preterm labor, the fetal growth restriction, and fetal anomalies. Next slide. So going through this slide, I'm just going to focus on that twins section there, the first column. You can see the birth weight, average gestational age at delivery for twins is 35 to 36 weeks. The percent of patients with twins who have IUGR in at least one fetus is 14 to 25%. In NICU admissions, at least 25% of these babies goes to the NICU. And importantly, up to 20% of these babies are delivered less than 34 weeks. So they contribute a great deal to our prematurity rate. Next slide. Now, there is a higher rate of birth defects and chromosome abnormalities in multiples, greater as you go up in the higher order multiple gestation. Serum multiple markers are accurate. We do AFP screening in these patients. NIPS is now offered by at least two companies that do NIPS, the Maternity 21 and Natera. Provide results for twins. Natera is the only one that also reports zygosity with those results, so that's helpful. And nuchal translucency is extraordinarily helpful in the first trimester, I think, because it has been shown that increased nuchal translucency is associated with a higher rate of twin-twin transfusions, heart defects, and chromosome abnormalities. So it can be very helpful in screening these patients. Next slide. So preeclampsia occurs in about 20% of twin pregnancies, higher in triplets and quads, obviously. The thing that's interesting about preeclampsia with multiples is that it tends to occur earlier in the pregnancy, is more often severe in nature, and frequently has an atypical type presentation, so it can be confusing. Very important to have the access to specialty care with those babies. We do use in our practice low-dose aspirin for twins and multiples because of the increased risk of preeclampsia, but the studies are a lot less convincing that there's a decreased risk of preeclampsia and multiples using aspirin, but there is a trend toward a benefit starting that at 12 weeks gestation, 12 to 16 weeks. Next slide. Busy slide, but I'm going to walk through this because there's several important things, and this is unfortunately a confusing area for even those of us who practice maternal fetal medicine, because there's very little agreement on lots of this stuff. We know the average delivery timing is around 36 weeks for twins. How do you screen for preterm labor? Well, you know, in singletons, we do cervical links. ACOG has stated that because of the effectiveness of interventions for multiples is unclear, that they cannot recommend for or against routine cervical measures in twin pregnancies. Now, we do utilize this because I think that it can alter our management. We'll talk about this actually with the case today as well. Studies have been done looking at prophylactic use of cerclage in twins, no benefit. Bed rest, no benefit. Pessary and progesterone use, again, for prophylaxis, that is just because the patient has twins, those are of no benefit. Vaginal progesterone, however, for a cervix less than 25 millimeters is very mixed in the twin data. There's just not a lot of data to firmly support it. There are some studies that show a benefit, some studies that don't show a benefit. So ACOG and SMFM really kind of say you can do what you want to. There's really not any firm recommendation one way or the other. Cerclage for short cervix in twins, again, insufficient evidence for or against. That is with a short cervix measured on ultrasound. An exam-indicated cerclage in the second trimester, that is a digital exam that shows cervical dilatation, cerclage does seem to be trends toward a more likely beneficial effect. So again, this is something that has changed in recent years. Treatment for preterm labor in those patients who come in is really the same as singleton. That is, with the use of steroids, the use of magnesium for neuroprotection less than 32 weeks, and obviously antibiotics for GBS prophylaxis. Next slide. So growth restriction and discordance. Discordance is defined as a difference in estimated weights by 20% or more. Particularly in dizygotic twins, discordant sizes really don't impact the outcome, particularly if they're appropriate for gestational age. So a difference in size doesn't mean that there's something bad or that there's going to be a poor outcome. And that's just important to understand, that we don't intervene for delivery just based on the difference in sizes. It may increase our monitoring of the patient, but it may not change our delivery planning. Fetal growth restriction, the definition is the same as it is in singletons, and that is less than a 10th percentile for estimated fetal weight or the abdominal circumference in one of the babies. And the management is essentially the same as in singletons, although the delivery recommendations may be a little bit earlier than they would be in the singleton. Next slide. So there's a lot of debate over antenatal testing with twin pregnancies. ACOG recommends that we start testing in dichorionic uncomplicated pregnancies at 36 weeks. Many people and many other groups suggest 34 weeks. I think you just have to have a plan in place. We start ours at 36 weeks in uncomplicated patients. Mo-di twins, we start at 32 weeks because of the increased risk of stillbirth in comparison to dichorionic twins. And as you advance gestational age, there is an increasing risk of stillbirth in both types of twins, but really leaning toward a higher rate in the monochorionic twins. So I tell folks all the time, if you have the potential of being confused and miss testing on Mo-di twins, trying to set up two testing plans for the two types of twins, just do both at 32 weeks so that there's lack of confusion. The bottom line is there is an increased risk of stillbirth in both types of twins as the gestational age advances. Next slide. And I think that's it for today. This is the wrap up in 2 weeks, not next week, but in 2 weeks, we'll talk about